creation of educational and outreach material, assistance with daily operations, identification and communication with a variety of stakeholders, conducting provider workshops, webinars, and various other speaking arrangements. Kim has over 30 years of background experience working with Medicaid and with a focus on provider outreach and education. Let's welcome Kim Davis-Allen and listen to her presentation on Florida HIT initiatives.
Okay, great. I guess that's my cue to start. Can everyone hear me okay? I will say that I'm from Alabama, and this presentation is much better in person because I use my hands when I talk because I am from Alabama. So, but I do appreciate the opportunity to get the message out about what is happening with Florida's health information technologies. It really is an exciting time. If you've been in this realm for a while, it's been a long time coming. I know many of you probably work in various forms of health IT within your own organizations, either from an actual day-to-day or operational level to conceptual planning. And I really do believe, I've done this for a long time, as she said, I really do believe we're finally getting to that point that health information technology is really going to become the norm. It's, like I said, it's been a long time coming. So let's talk about what health information technology is. So when we talk about health information technology, and in my role, I really do focus a lot on the EHR incentive program, which drove a lot of provider organizations to adopting electronic health records, looking for ways to be able to better exchange patient information, looking for ways to better engage their patients. But when we talk about interoperability, there's lots of different things that, at least in our purview, kind of comes under that umbrella. You know, we talk about health IT, we just talk about the information. There's so much information out there, and we really have moved away from paper-based records, from faxing, though I know a lot of people still like faxing, from patients requesting paper medical records, but we still have those individuals as well. But there's so much information, and a lot of what health information technology does is look for ways to use that type of information. Oh, sorry. You know, it's technology. I did a webinar yesterday, and we were talking about patient engagement, and one of the things that we really focused on is that technology really is just the plumbing of what you're trying to do with all of your information. And again, y'all probably are much more versed in this and how it really kind of happens on a day-to-day basis within your organizations. But, you know, when we talk about technologies, lots of different things that technology represents, and how can that technology better use you to do patient care, to use the information, to be interoperable. And these are just different words. Again, this is focusing on the EHR incentive program. There's lots of different things that have happened over the last 5 years, 6 years since that program has begun. But I think exchange of that information is key. Within the Meaningful Use program, there's direct requirements to be able to exchange patient information, but that again is just a derivative of health information technology or interoperability, you know, whatever buzzword you want to use. ICD-10 and telehealth, data analytics is huge. Population health, we hear so much about population health. And again, having done this for so many years, there's always been a form of population health. Public health really took the lead on a lot of that population health. But as we're moving to different payment models, as we're moving to the accountable care organization realm, and insurers are doing more value-based care programs, you know, data analytics, population health really does become a lot more critical in being able to better understand who your patients are, what your patients need, and what kind of services and programs that you may need to create to serve those patients. Just a couple of more things. Patient lookup, being able to find that patient information. Patient portal, meaningful use, huge. And again, a lot of the drivers of those have been the EHR incentive program. You may be hearing a lot more about what they call ADT fees, admit discharge transfer fees. That's really getting a lot of traction. It's always kind of been in the background, but through those ADT fees, insurers, providers, even sometimes patients or caregivers of patients are notified when patients may be going to the hospital for services. Maybe they're going in as an inpatient. Maybe they're seeking emergency care services. But it's really good real-time information that allows you to better coordinate the care for that patient. coordinated care. Couldn't have planned that one better. So when we talk about health information technology, it's all these things. It's not just one particular piece. It's a lot of different things that work together, to work in concert to kind of make up that umbrella of health information technology. And while there's bits and pieces that are the same across each organization, they're all different as well because each organization is different. And, you know, hopefully as we mold these programs and as the federal government becomes more responsive to what providers need, they do realize that. So interoperability, that's the buzzword. That's our buzzword of the day. What is interoperability? So within health information technology, we talk about interoperability. And it's just what it says. It's being able to interlink a system, information, or workflow. It's that exchange of information. It's the ability of two or more network system devices, applications, and components to talk to each other. There's an app for that. There's an app for just about everything I've just said. And then, of course, you know, you need to be able to externally exchange and readily use information securely and effectively. Privacy is really big. Security is really big. We laugh sometimes about all the different data breaches and things that are going on, but that's a real concern, not only from the patient's level, but think from the organization's level. So it's real easy to talk about interoperability, sharing patient information, sending patient information through these systems, but from an organizational standpoint, there is that real concern of how can you keep that information secure, how can you keep that information private, but at the same time meeting the patient's needs. So why do you need interoperability? Well, that's a good question. I think one of the biggest things that we really are beginning to see is that patients expect it. You know, patients want to be more informed. Patients want to be more involved in their decision making. And from a provider standpoint, it just makes sense that a provider would have better access to information, total patient information, longitudinal patient information when making healthcare choices. I had a statistic yesterday that I can't remember the exact number, but the number of patients 18 to 34 who do not have a regular physician, they go to urgent care. They go to the emergency room when it's bad enough. That's just how they seek out their medical care. And if that patient is going around to multiple providers of care, then each of those individual providers of care need to know what's going on with that patient. And again, I think patients do expect it. They expect to be able to go to wherever they need to for care and have their information available, to have access to their information. You know, the key there is that information is following the patient's not following information. Recently, my husband had a fall, and so we've gone to multiple providers over the last 6 weeks. And, you know, some organizations do this a lot better than others. I've got a file folder, you know, like in days past of all of the different tests and the different things that have been going on. And then when I get to some provider organizations, everything's already there and it's already online. So yes, it does create a certain expectation that if one person can do that or one organization can do that, I would want all of my healthcare providers to be able to do that. And I think probably the biggest driver, much like the EHR incentive program, you know, kind of drove the first part of this, is I think that the quality payment program is really going to start driving a lot of what we have to do, ways that we have to be interoperable, ways that we have to exchange that patient information. You look at the PCMH program or the MACRA program, or just how Medicare in general is paying for value-based care. All of that really does kind of come into play. So when we talk about interoperability and health information technology, who's really involved? Well, everybody. The patients. And, you know, as I tell people all the time, you may not be a patient today, but at some point you will be a patient. So when we think about programs that we develop and rules that we impose and concepts that we start developing, you know, think of yourself as a patient as well, because at some point you will be a patient. Definitely our healthcare providers. I really do feel for healthcare providers because there's more and more every single day. And again, in researching and just trying to keep abreast, you know, providers really feel very much burdened by technology in some respects. They feel like they're spending more time keying into a computer versus really being able to spend with their patients. And that's not the way it's supposed to be. So how can we support the providers' use of technology, the need for technology, but at the same time preserve that provider-patient relationship? And it does vary. It really does vary based on the provider, the patient population, the setting. But again, I think that's something that we have to be mindful of. Caregivers, like I said, you know, if you're trying to navigate that healthcare system, it can be very challenging. And up until the point of his accident, you know, we were healthy. Went to the doctor once a year because our insurance required it. Other than that, we didn't have to. But it's very complicated. It can be very hard for someone with limited resources to be able to navigate the healthcare system. And there's ways that technology can really support that. And of course, the insurance companies and the health technology vendors are all involved. A lot of times, because I do concentrate so heavily on the EHR incentive program, I hear from providers all the time that they thought they're being held hostage by their EHR vendor, that these HIE systems that were supposed to do all these great things are not necessarily going to be able to do what they thought they were going to be able to do, and more importantly, what they paid for them to do. So there's a lot of different layers when you talk about interoperability, and I think one piece that we tend to overlook is telehealth. Telehealth is really becoming big, especially here in Florida. Speak just a little bit about the Telehealth Advisory Council on a later slide, but telehealth is also has been around. It's not new. There's different variations of it, just like a lot of different health information technology programs. But it's something that I think providers will need to embrace more, and that patients, again, we're going to expect more. They're not going to want to have to travel to see a doctor when they can pick up their phone or use their app for that. So let's talk about Florida. Most of y'all are from Florida. I assume probably most all of y'all are from Florida. So let's talk about what's going on in Florida in terms of health information technology. Because like I said, it's a lot of cool things going on. I really think a lot of the time has come for things and the progress that we've been working on to this point. So we talk about what we're doing from a state level, kind of in the broad term of the Florida Health Information Exchange. But that really does make up several different programs. I work for the Agency for Healthcare Administration, and we are responsible for administering the Florida Health Information Exchange and the various programs that come under that title. So our mission is better health care for all Floridians. And in terms of looking at that and trying to apply that to the programs that we administer, we really try to make an effort to make sure that the programs that we're administering do support that bottom line of that patient, that better health care. And everybody's a little bit different. Some patients need a lot, some providers need a lot, others just need that routine annual physical. So what can we do? How can we support our patients and providers and still serve our mission of better health care for all Floridians? So in terms of carrying out some of the requirements of being in charge of the Florida Health Information Exchange, we definitely partner with Health and Human Services, CMS. Now in Florida, CMS also means Children's Medical Services, but in our world, CMS also means the Centers for Medicare and Medicaid Services. I can't imagine anyone on the phone who is not involved with them in some shape, form, or fashion, either from a licensing, or regulatory, or payment side of the house, or even just kind of knowing what's going on at that federal level. We have technology vendors that we work with. We have some really good solutions that we are able to offer to providers to help them not only meet meaningful use, but be able to exchange patient information, and we're transitioning some of that. Technology changes, and we're trying to be adaptive to that as well. And then, of course, local stakeholders. If you're not familiar, back in 2010, when all of the funding for the meaningful use program and health information technology exchanges came out, Florida created the Health Information Exchange Coordinating Council to help guide our decision making. All this information is available on our website. So we have governance for 3 main programs, including the EHR incentive program, our patient lookup service, direct messaging service, and our event notification service.
Kim, hold on just a second. Whoever just joined, can you please mute your phone because we hear all of your conversations? Thank you.
You knew, I guess. I've got a couple of them like that where you just write your name on a card.
We'll give them just a minute.
Yeah. So for everyone that's on the call, can you please mute your phone? Someone just joined and we can hear all of your conversation.
Okay, that seems to have taken care of it. So when we talk about patient lookup and we talk about health information exchange, we laughingly say it's a noun and a verb. So health information exchange is just that exchange of information. It's basically that interoperability. And to date, we have a health information exchange noun within the state of Florida. But we also talk about health information exchange as a verb, which is the active exchange of patient information. We are actually transitioning some of our patient lookup services, health information exchange services, to a different platform. What we have found is we have a service here in Florida that people are able to exchange patient information for. There's also a national health information exchange that allows patient lookup, and we see that a lot of our individual participants are moving towards that platform. So we're working to see ways that we can support them towards that move. And quite honestly, back when the program began back in 2009, 2010, there wasn't that national exchange capability. So I say that just to let you know that when I talk about patient lookup, I'm talking about it not only as the service that is being currently offered in Florida, but also that bigger concept of being able to exchange patient information. So these are the statistics of the services that were currently offered in Florida. And again, as we move towards more of a national exchange, it really serves the same purpose. It allows providers to electronically exchange summary of care records. They have the ability to take that information from other providers or the organizations and kind of assimilate it into their own electronic health records, depending on what their preferences are. They can do that clinical reconciliation, which is necessary for being able to get a better picture of that patient, and in long term is going to be required for some stage 3 meaningful use type requirements. Our current patient lookup partners in Florida, as you can see on the screen. But like I said, we're really moving towards more that national platform, because what happens when we move towards that national platform of being able to exchange patient information is that you're truly able to exchange patient information across city lines and state lines as well. So in Florida, especially in South Florida, as our snowbirds come down or as our snowbirds go home, that information can follow that patient through the national exchange versus that patient having to, gather their information and make sure whoever they've been seeing, either north or south, has their direct patient information. The one thing I do want to say about patient lookup services, there is some funding available to organizations that we can help you with your integration costs. So if you're someone who's thinking, I do want to do more with health information exchange, I want to be able to do patient lookup type services, we do have some funding that could help you offset some of your integration costs. You can either connect through someone who is already participating, or you can do a direct connection. The biggest requirement is that you have to be a hospital or a provider group that is eligible for the EHR incentive program. So if you're struggling to meet some of those meaningful use requirements, transition to care, that type of thing, and you see this is a good avenue, get in touch with us, because there may be some funding that we can offer to you to help you be able to not only hook into that national exchange, but also to be able to meet those meaningful use requirements, and hopefully above and beyond meaningful use, really use it to improve the patient experience, to improve your ability to get patient information. So funding opportunities are out there for that. Our other big service that we get a lot of traction on, and that really helps providers meet meaningful use, is our direct messaging. Now, if you're familiar with your certified system, and I know not everyone works directly with their systems, there is supposed to be in there, based on the current certification requirements, the ability for you to be able to safely and securely send messages. They call that the direct standard. Direct is just a series of accreditations that allows you to securely send information. The problem that we find is that a lot of providers are not aware that these systems are available within their EHR. They don't really know how to get to them, or there may be additional cost in order to be able to access that service. So while all systems should have direct capability, well, again, that's a noun and a verb, we find that a lot of providers just really can't get to it and can't really use it. So we do offer a service through a company called NEFHIMA, and it's basically a direct messaging service. It is a web-based system that allows, that you do like Gmail or whatever other system that you would have, that allows you to be able to send patient information and meet HIPAA requirements. So within Florida, we have about 50,000 addresses that are available to you. So let me back up a little bit about what direct messaging is. So again, it's a web-based application, which is an email service, but it is safe and secure. The big thing about the service that we offer is even if who you're sending patient information to is not enrolled in our email service, you can send it to their regular email. They are notified, and that does count towards meeting those meaningful use requirements of, having reasonable certainty that someone has received your message. So when we talk about direct messaging, we talk about it in terms of what the requirement is for meaningful use, that sharing of patient information. And then there's also a component of direct messaging which talks about accreditation. So within the big world of certification, Direct Trust is an accreditation that email services can go through that allows them to share information outside their own organization. So for example, if I'm signed up and my email system has Direct Trust accreditation and I'm trying to email or communicate with another service who also has Direct Trust accreditation, our two systems can talk to each other. If my email service does not have Direct Trust accreditation, then I am limited to only using that service with other people who are signed up for that individual service. We see this a lot with EHR systems. If you're an Epic user, you can communicate with other Epic users, but if you try to communicate with a Cerner user, unless those systems are Direct Trust accredited is key word, then you cannot communicate outside your own organization or your own EHR system. So we get a lot of confusion about this. So direct messaging is a service we offer, but we also want providers and organizations to understand what direct messaging means in terms of their own organizations. So in trying to explain this, and I still don't think I explained it very well, we have a visual. So you have all these different kinds of email services. And all email services have to meet the direct standards. That's the HIPAA compliance standards. But only if they're Direct Trust accredited can those systems actually communicate with each other. So again, Epic users probably can communicate with other Epic users, but if you're trying to communicate Epic to a Cerner or whatever, unless those systems are Direct Trust accredited, you're limited in who you can exchange information to. In terms of direct messaging, we really encourage our providers to see what they have available within their own systems. It's just easier. You've already paid for it more than likely. It's more integrated. You're able to easier pull patient records and send patient records and assimilate patient records. But if that's not available to you or if it's just not working for you, no, there is a standalone service that you can use through the Florida HIE. All right, event notification. This is the other one that is just really taking off. Event notification is that ADT feed. It's using that information from the hospital, either inpatient or emergency room, to let people know when someone has gone in for services. So we have all of the hospitals, well, about 94% of all acute care hospitals in Florida send the information. Right now it is being sent to health plans and ACOs. Because those are the individuals who are really taking that information, usually following up with that patient, referring them back into care management, finding out why they went to the emergency room versus maybe going to their primary care physician. So basically, if I go into the hospital, my either health plan or my ACO, if they're signed up, is notified that I went into the hospital, why I went in the hospital, and then they get that information real time, usually within 24 hours, to kind of follow up with me. Participation, like I said, we have 94% of all hospitals, 8 health plans, 24 ACOs, and we're working on a model and have some pilots just about to kick off that takes it down even more to the individual provider level. So maybe, you're not really as involved with a health plan, you're not really working with an ACO, but you maybe have a really large group and you say, hey, I need to know when my patients are going to the hospital as well. There's some funding out there. There's also some connectivity that you can also get that type of information on your patients. We're seeing more of this going on in other states because it does provide that real-time patient information. and that it's also more of an alert versus you having to kind of go out every single day and saying, hey, did anybody go to the hospital? Did anything like this happen? It is sent to you versus you having to go out there and actually look for it. And here's just a graphic on the number of alerts that have been delivered since 2015. As you can see, the numbers are definitely going up. Getting a lot more interest from ACO and other insurance companies as well. So I think you'll see these numbers continue to increase. So like I said, there are some funding opportunities out there. All the information, I have a contact slide at the end that can talk to you a little bit more about how you can avail yourself of these services. All right, so let's get into the heart of the matter, the EHR incentive program. Well, the EHR incentive program is definitely always undergoing changes. I was looking back for past program requirements, trying to verify something for a provider, and was really reminded of just how much that program has changed and evolved from when, 2011, when it really first kicked off, especially down here in Florida. So these numbers are a little dated, maybe a couple of weeks old, but to date we have paid almost 14,000 applications, and that represents about 8,300 unique providers. And the reason that that's important is that, when you first came into the program, first year payments were the big payment, the $21,250. So those payments, we had a lot of people come in, and then there was really concern whether or not people would come back for the program, because in subsequent years you have to actually be meeting meaningful use requirements. And not only are some of the meaningful use requirements kind of onerous for some providers, they constantly change. You get kind of on one path, and in the middle of the year CMS changes it, or you get down, you're thinking that you're going to be trying to attest to stage 1 or stage 2 and then come up with modified stage 2 or whatever. So the bottom line is it was constantly changing. So the concern was that we'd have a lot of first-timers and we wouldn't have a lot of people come back. But we're still running the numbers, but we have about a 35% return rate. That seems low, but that's about average across the country. And I truly hope that now that the program has kind of leveled off with modified stage 2, that a lot of providers will at least come back in for the subsequent years. Don't really know what's going to happen with stage 3. It's supposed to kick off next year, 2018. I just think in my heart it might be postponed a little bit, but again, I hope to see that retention rate go up a little bit, because not only does meaningful use get you an incentive payment, but it really does provide a good platform for patient management. People have invested a lot of money in these EHR systems, and I hope that they will really fully utilize them in a lot of different capacities, not just to get the incentive payment, to really support health information technology, to really exchange those patient records. But let's talk a little bit more about meaningful use. So these are the modified stage 2 requirements. And again, I can't look at you and you can't really get a good poll of how many people are actually doing meaningful use, how many people are doing applications, that type of thing. So I'll kind of talk really high level, but of course if you have any type of specific questions, I'll be glad to take those as well. So what Modified Stage 2 did back in 2015 was it set forth a single set of objectives, which is what the program should have done to begin with. And everyone attesting has to attest to that one set of objectives and measures. Now, depending on your program participation, year, level, how many times you've attested, you did have some alternates, exclusions. There were a few variations, but for the most part, everybody knew what the measures were. And these are what the measures are. So there's 10 that providers are currently having to attest to. So it's been the same for 2015, 2016, and 2017. And again, like I said, 2018 is supposed to bring on stage 3. So these are kind of the time frames. So in 2016, all providers attested to a 90-day EHR reporting period, and like I said, there were some alternate measures and exclusions. In 2017, all providers will again have a 90-day reporting period. Now, and if you're in the middle of meaningful use and trying to meet the measures, 90 days is really important to you. It was a full year for returning providers, so you didn't really have a lot of wiggle room in missing measures and things along those lines. And I think there is some recognition both at the state and federal level that some of these measures are harder to meet than others. So having a 90-day reporting period really allows you to be able to adjust that and run your reports, work on problem areas and that type of thing, and not be totally shut out of the program. Probably the biggest thing is for 2017 is if it's your second or later year of reporting meaningful use, is that you have to report a full year of clinical quality measures. Now, let me back up. Within the meaningful use program, you have your meaningful use measures and you have to report clinical quality measures, and those two timeframes are usually the same. But for some reason, for 2017, and we think it was just an oversight, everybody reports 90 days of meaningful use measures, but second or later year reporters have to report the full year of CQM. So just kind of keep that in the back of your mind. In terms of modified stage 2, a few things changed, but not significantly. And again, everybody kind of knew for the next few years what they were going to have to attest to. And again, stage 3 is supposed to kick off in 2018. The big thing with stage 3 in 2018 is that regardless if it's even your first time of attesting to meaningful use, you have to attest to those stage 3 measures. So for those providers who are just coming in, they have some pretty high thresholds that they have to meet. So in terms of how meaningful use relates to kind of what we're talking in terms of health information technology, that type of thing, these are the key measures within meaningful use that kind of support the need to be able to share patient information, that support that concept of interoperability. You have to meet all of them, but these are the ones I really want to focus on. Probably the biggest one and the ones that we get the most complaints are health information exchange. That's using your system to create the summary of care records, and for 10%, actually more than 10% of your transitions of care and referrals, you have to electronically transmit that summary of care record. That's where that direct messaging really comes into play. Some of these systems are equipped. It's easy to send this information out. Most every system can create it, but it's actually that mechanism for sending it out. If your system can send it out for you, that's great. If not, direct messaging may be a really good option for you in order to be able to not only get this patient information out, but also to meet this meaningful use measure. The only exclusion is if you refer less than 100 patients during your EHR reporting period. And depending on how your practice is, what you practice, that may be relevant in a 90-day period. Patient electronic access, this is that patient portal. I could talk for days on patient portals, but they're critical. And I hope that providers, again, once they've invested the time and money into it, will really take advantage of the patient portal model. There's lots of really good things that can be done through the patient portal, but in terms of meaningful use, more than 50% of your patients have to have all the information necessary to view, download, or transmit. And for 2017, at least 5% of those patients, or more than 5% of those patients, actually do something with the information. Like I said, we can talk about patient portals. Some practices love them, some hate them, some patients love them, some patients don't. So there's lots of different things that you have to think about when you're implementing your patient portal and really trying to get your patients more engaged into using that portal. And then the third thing is the secure messaging. This is that ability for those patients to be able to communicate with you. The measure is on the physician responding or generating the message, but I think it's important to think of in terms of the concept of secure messaging. Your patient can actually initiate that. The provider respond to it, the provider's office respond to it, and it satisfies the requirement that more than 5% of your unique patients during your EHR reporting period are set a secure message. So all of these things are those particular meaningful use measures that actually really are relevant to health information exchange and health information technology. So as we look at stage 3, they don't go away, they actually really do increase. The number of overall objectives decreases, but as you can see within the individual objectives themselves, the measures expand and increase. So the first one, the view, download, transmit, whereas it's 50% now it's more than 80%. And not only can you meet this measure through direct interaction with your patient portal, if you have an ONC certified API, application programming interface, then that can also count towards meeting this particular measure. The second part of this objective is that more than 35% of your unique patients receive their patient-specific educational resources. Another really good use of your patient portal. This has been 10% since the program began. Now it's gone up to 35%. Not really sure why they lumped under the two amongst these two measures of this one objective, other than this is a really good use of your patient portal. The second one that still supports the need for health information exchange, and I actually, on the slides that I sent y'all earlier, I had these percentages wrong. I do apologize. They changed them. So I do have an updated slide for this with the correct percentages based on the CMS specification sheets. But the point with this one is that more than 10% of your patients have to view, download, or transmit, or use that API. More than 25% of your patients have to have that secure messaging. That went up a lot from 5%. And then lastly, more than 5% of your patients, you're using non-clinical information and incorporating that back into your EHR. Or I say non-clinical information generated from a non-clinical setting. This is where your wearables come in. This is where your remote monitoring came in. So again, having that patient engaged, looking at technology to be able to support these particular measures is really going to be critical. And we think about 2018 is still, what, 8 months away, 7 months away? Well, these first 5 months of 2017 have flown by. I can't wait to see what happens with the last 7 months. And then the last one, again, in stage 3 is that health information exchange. So it goes up from 10% to 50% for those transitions of care. Get that summary of care record. 40% of the transitions, you have to incorporate a summary of care record. The measurement's always been that you push that information out. Now it's actually going to be looking at pushing that information in as well. And then lastly, as more than 80% have a clinical reconciliation. So when you're looking at these measures, some of them you have to meet all of them, some you have to meet 2 out of 3, but you still have to report on all of them. Again, think of the different ways that technology can actually help you be able to meet these meaningful use measures. I'm going to have to start talking faster. So just a few things. Patient engagement, I think, is really critical. Patient portal use is really critical. These are just some statistics when we talk about what patient engagement is and how patients and providers look at interoperability and health information exchange and all those key buzzwords. This is according to HIMSS. 52% of hospitals currently use 3 or more connected health technologies. 47%, and these are hospitals, expect to expand the use of connected health information technologies. And again, technology is just a tool out there for you. I think the trends that we'll see is a lot more increased patient engagement, not only to meet meaningful use, but also to be able to comply with some of the value-based care programs, to be able to comply with individual insurance requirements. And that's just, I think, what our patients are going to really expect as well. Definitely more use of the patient portal. And I'm really trying to tell providers that when you're looking at patient portals, make them work for you. Look for different ways that you can really make that patient portal not only satisfy what your patient needs, but to kind of help your business plan as well and your business processes. And don't forget our application interfaces. There's an app for that. There's just about an app for everything. So quickly, just patient engagement defined by providers. It was just kind of interesting, when you're doing research and you're looking at all these different things, you can find studies and statistics to support just about anything. And it really is interesting the different perspectives that providers have on patient engagement and the perspectives that patients have on patient engagement. But from a provider perspective, I think the biggest thing is taking that active role in improving their overall health. Not just coming to the doctor when you're sick, but other things that patient can do as well. And some of the technology, some of the apps, some of the APIs can kind of help support some of those, that involvement. From a patient standpoint, we talk about the portal. This is what the millennials use the patient portal for. 33% of them use it just for basic communication. It's so easy to send an email, send a text, versus picking up the phone call and playing phone tag back. Online reviews, we talk about technology. Social media is huge in provider practices and healthcare organizations, but it's a real sticky situation too. But I know that now people go online. If they're looking for a doctor, they don't always ask their friends anymore. They go online, they look for reviews. And you type in a doctor's name or a hospital's name, and you can find anything and everything that you possibly want out there. So social media is really big. Managing all of that's really huge for our provider organizations, but I think it's something that providers have to pay attention to because it's part of that patient engagement, and people use it. People use online reviews when shopping for a physician. All right, so quickly, I get the question, what is an API? An API is basically an app for that. Netflix is an API, Amazon's an API. If you have a really good patient portal, you could develop an API that allows other patient portals to talk to your patient portal to make it more convenient for a patient instead of having to go to multiple patient portals. You'll see a lot more, think about these things as time goes on and they come out. The big thing with the APIs, and as you're looking at that technology, in order to qualify for meaningful use, they do have to be ONC certified. I haven't seen a lot about that certification criteria, that certification process, but I think we'll see more of that, especially as we get closer to the end of 2017. Just briefly about MACRA. Telehealth. I told you a little bit about telehealth. If you're not aware, there is a telehealth advisory council that was created by the legislature last year. Really cool things that are coming out of that. I think it has been a real eye-opening experience to let people know what all the uses of telehealth are, some of the benefits of it, some of the barriers to it. The purpose of this committee is to look and provide a report to the governor of better ways that people can use telehealth, maybe better ways that we could pay for it, we being ANCA. Legislation could be written. So telehealth, there's a website out there that has all the past minutes, testimonies, things like that. So again, I really encourage you to look at that just because there's some really cool things. My favorite was PT, telehealth PT, and how beneficial that is. Because, you know, PT usually is not a pretty abbreviated visit. So if somebody has to drive a couple of hours to do 15, 30 minutes of PT, they're not going to be the most compliant patient, but if they can do it over the phone or through the prompt or whatever, however they want to do it, it's really cool. Okay. Oh, running out of breath. So MACRA, just real briefly about MACRA, because I do want to have some time for questions. Y'all probably know more about MACRA, but a lot of the groups that we talk to, you know, just say, kind of tell me what that MACRA is. The basic thing for MACRA is that it is replacing the Medicare EHR incentive program. It doesn't affect what we do under the Medicaid incentive program, and some of the measures do line up, but basically it is taking a bunch of different quality payment programs that the feds have been administering and kind of rolling them up to one. Under MACRA, under the quality payment program, there's kind of like two different ways that providers can participate. The MIPS, Merit-Based Incentive Program, which is very much like what they're doing now, or the alternative payment model. Most of our providers are going to be participating under MIPS. We don't have a lot of providers that do alternative payment models right now. And this is only for those Part B clinicians. It doesn't affect hospitals. So who's in the quality payment program? The QIP. You've got to have a lot of acronyms if you work for the government. It would be those providers that bill Medicare for more than $30,000 a year and provide care for more than 100 patients. So again, when you're looking at whether or not this is something that does affect you, there's definitely qualifications out there about who is going to be included. We have included the source or the website that you can go out and do your own research if you need to do more about MACRA, though I will say it's been around, it's been announced long enough now that I think a lot of organizations have already looked at it, tried to get a plan of action. There are services and funding available for organizations to come in for some of our smaller practices and help you determine what exactly it is you need to do in order to be able to qualify. The big thing under the quality payment program is that it is kind of a schedule. 2017 is going to be the first year that you're actually collect your information. 2018, you send in your information, much like meaningful use. Also in 2018, you get feedback, and then in 2019 is when the adjustment would be applied. And it can be a positive or a negative adjustment. And much like a lot of the programs released by the feds, you know, they had kind of a set of standards, got a lot of comments on that, and kind of backed off some of the standards. So there is time for providers to really be able to do more research and find out exactly what they need to do for this. Alternative payment models, again, there's not a lot of federally recognized alternative payment models, but we put this out there just so that you know that that could be an option. If you're participating in an ACO in some of our patient-centered medical home projects, you potentially could participate in the macro program under that. But again, you'll need to do your research and find out what those standards are individually. NEPHIMA, again, just takes a lot of the different programs that are already out there and rolls them up into one. The good thing about NEPHIMA that's different from the meaningful use programs is that you can participate as an individual or a group, and it is not an all or none type program like meaningful use was. You know, meaningful use is, even for Medicaid still, is you have to meet all of the measures or you get nothing. Under MIP, it is based on your participation scores. The Pick Your Pace, like I said, that just gives providers a little bit more time to figure out exactly how they're going to participate, what they need to do internally to be able to fully participate. So the big thing is if you don't do anything, then you're going to get a negative adjustment. If you just submit anything back in 2018, regardless of what it is and what your threshold is or whatever, you're going to be made whole, or you're going to remain whole. If you submit a partial year, you could potentially get an incentive, and if you submit for the full year, then again your incentive will be even higher. The big takeaway here is if you do nothing, you're going to get hit with a negative 4% adjustment. If you do something, then you can kind of better control what that incentive payment may be. It may be nothing, but at least it won't be an adjustment. And again, especially for our smaller practices, there are resources available to you locally to help you come in and better figure out exactly what this means and what you need to do within your practice to be able to fully participate within this. These are just the categories. This is the old meaningful use program. Cost right now is not being measured in 2017. That will pick up in 2018. These are the different categories. Just point out right here, these are the categories with under the advancing care information, aka meaningful use, that you do have to meet. You will notice that when you do your research on this, the standards are a lot lower, whereas we have 30, 40, 50% thresholds. Many times this is one patient, the capability, that type of thing. So if you're currently doing Medicaid meaningful use, you can also participate in the MACRA program as well. You can now receive payments from both programs, and if you're meeting Medicaid meaningful use, then you're going to be able to meet the requirements under the MACRA or the Merit-Based Incentive Program as well. Lastly, just want to point out, I don't know if y'all are aware of this service, the Florida Health Finder. It is just a really good service that allows you and allows your patients to be able to go in and compare healthcare providers. They have a lot of information on nursing homes, hospitals, assisted livings. We're really trying to get the word out to let providers know, to let providers and patients know that this service is available out there. Since it's more, it's not a Yelp review that somebody can just place out there on Google. You know, it's documented, statistically based information to help providers, I keep saying providers, patients make, healthcare choices. See the most use of it for nursing homes and assisted livings. So if you're trying to find those type facilities for your family members or friends or whatever, this would be just a really good resource to be able to go out there and find that type of information. Okay, so here's our contact information. This is how you can get in touch with people for the EHR Incentive Program, Florida Health Finder. Here's lots of good stuff on that Telehealth Advisory Council. Again, really encourage you to go out there and see what's going on. They've had different meetings throughout the state, so you might find that meeting that was held locally and find out about local programs that you are not aware of. And of course, all of that information about the Florida HIE can be found right there. So let's take questions. Does anyone have a question or a comment?
Okay, we have no questions.
Somebody want me to go over something in a little more detail?
Wait, go back.
For those who are doing the EHR incentive program, we are actively reviewing our 2016 applications. You're going to be attesting for program year 2017, we did have to make some system changes based on some CMS changes. So the system is not going to be open for 2017 applications till probably late summer. They're saying August timeframe. So in the meantime, I would just be kind of gathering my information, checking my numbers. As I said, because it is a 90-day period, if you're having trouble meeting certain measures, you can run your reports, adjust workflow, whatever, to see if you can meet them in different EHR reporting period time frames. And we'll definitely let people know when that system is up and running so they can get those 2017 applications in. The big thing for that, again, if it's your second or later year for reporting meaningful use, you are going to be required to report CQMs for the full year. So even though you may have a 90-day period that ends before December 31st for meaningful use, you're still going to have to wait to the end of the year to be able to report your CQMs as well. So we expect to see most of our applications being filed the first quarter of 2018.
Okay. Well, thank you, Kim. We really appreciate it today. Very interesting stuff. Lots of great things coming. So
yes, we think so too.
Yeah. All right. Well, thank you again. And if no one has any questions, we're going to go ahead and close the meeting.
Okay. Thanks, guys.
Thank you. Thank you.
Hey, Lee, can you hear me?
Yes.
Thank you.
Hey, Lee, can you hear me?
Yes.
Hey, Lee, this is Dale. I was having trouble getting the download of the PowerPoint presentation, and also maybe get the contact information of the presenter.
Yeah, we can send that to you.
Great, thank you.
Okay.